In recovery management, we use this language. When we talk about assertive continuing care, we're talking about post-treatment monitoring and support, meaning we're checking on people, and while we're checking, we're supporting them. We're doing stage-appropriate recovery education and coaching. Meaning what? Stage-appropriate recovery education and coaching. Are there some very predictable early recovery questions for people recovering from methamphetamine or cocaine dependence? Related issues related to food and diet and sleep and teeth, and I could go on and on with this list. Yes. So what do they need to know? Rather than give them all the lectures about the disease of methamphetamine use, we got to say, what's normal recovery like? When are my sleep patterns going to get back together? When am I going to gain weight? And how do I gain weight? And what do I do with these nasty teeth in my mouth? I mean, you got some key questions. We know when those questions arise. And we got a world of collective recovery experience to guide that person through those. That's what we mean when we talk about this kind of recovery coaching. Assertive linkage to communities of recovery. I didn't say passive. Passive linkage to communities of recovery is, the good news is participation in recovery communities can dramatically elevate long-term recovery outcomes. Good news. Good news. When people are assertively linked to those communities, affiliation and participation rates significantly increase. The bad news, most people in addiction treatment programs are passively linked to these communities, meaning they are verbally encouraged to go and at best handed a meeting list. We have studies where we've encouraged people verbally to go and given them a meeting list, described even transportation, how to get to those meetings, and we came back later, nobody got there. I mean, we've had zero participation rates related to the effectiveness of passive linkage. When we talk about assertive linkage, what are we talking about? Taking them there, linking them to not to a particular meeting, to a particular person. Let's come back and talk about our women again, can we? If we got women with these chronic self-defeating styles of these loser relationships, long predatory histories of picking men, aggressive, violent, are there some meetings we want to keep them as far away from as possible? We got to tell the truth sometimes. Some group consciences are stronger than others, right? Some groups focus on 12 and some focus on 13, right? There's another way to put it. So my point is, if we're doing assertive linkage of women coming out of these programs we were discussing at break, are there specific meetings we want to get them in to assure their physical and psychological safety and the lack of diversions? Yeah, absolutely. That's assertive linkage. If and when needed, early reintervention and relinkage to treatment and recovery support groups. When we are in their lives and use returns, what level of problem severity are they at? Yeah, it just started again, right? They may even back into the early honeymoon period, but they're kind of panicked around it. So we've got low problem severity. What did I tell you about low problem severity? We got good prognosis. When people just got a little bit of a problem, we got a great prognosis for that. And guess what? They still got a lot of recovery capital they built up through treatment and early recovery. They got people around them, right? They got social credit. People started believing in them again, offering help and support to them. If we reintervene now, the prospects of restabilization are great, as opposed to waiting for 4 months until they've destroyed all of that and now they're back in crisis. The focus is not on a service episode, but managing the course of the disorder over time. Let me tell you how different this is. I want to contrast recovery management, assertive continuing care, from continuing care as usual in the United States. Number one, first off, most of you are going to do continuing care for your graduates, agree? You got to successfully graduate from treatment to participate in continuing care. Yeah, I do too. But in the acute care model, that's what we do. We graduate people. It's done. So what do we want to do if we're talking about long-term recovery management? Get rid of this word. What the hell is graduation in the context of a chronic lifelong illness that's going to need active management? Yes? Can you speak very clearly? Go ahead, try.
You gotta say that all over.
Yeah, no, I can summarize your question around how long should somebody stay in aftercare. First off, I want to say we need to eliminate that word forever. Because aftercare suggests what? You had the really good stuff, the important stuff. And now we just need to make sure we maintain our good work so you don't screw it up. That's aftercare. In a chronic care model, there is no aftercare. All care becomes continuing care in the context of management of a chronic disorder. So we're going to talk about continuing care, and if we answer that question, the question is going to be, we need to stay involved in their lives until they can individually or with family resource manage this on their own. So with some chronic disorders, that may be exceptionally, they may get this very stabilized, and they may need no specialized help and can monitor it through their primary care physician. In the addiction world, what did I tell you about stability? 5 years. Now, let me hear you. I don't want you going back and said, Bill said we should fund 5 years of treatment. Because I ain't talking about treatment. Everybody hear me? I'm not talking about 5 years of primary treatment. God forbid. What am I talking about? 5 years of low-intensity monitoring, support, education, and the potential when needed for reintervention back into primary care only when it's needed. And when you use that model, by the way, when people need restabilization, it generally requires very, very short periods of stabilization. We're not talking about running people back through cycles of 30 or 60 days of inpatient treatment. What did I tell you earlier? They know how to initiate recovery. That's not the issue. The issue is to come back, how do we identify the difficulty around recovery maintenance and move them back into that world as quickly as possible with supports to do that. Number two, the responsibility for contact. If David and I are running aftercare groups 2 nights a week at our agency, and people can randomly come to whichever group they want. And I come to David and I said, has Bernie been in your group the last few weeks? And he'd say, no, I haven't seen Bernie. I ain't seen him in mine. And David and I sit and mourn the loss of poor Bernie. Ain't neither one of us picking up a telephone. We're not making plans to go get Bernie because what? That would be codependent on us, right? That would mean we might need some treatment ourselves if we got involved in that kind of rescue work. I mean, that has been the attitude, has it not? That's the old world. In the new world, guess what's going to happen? It ain't going to be a casual, we're already knowing we lost Bernie. I mean, the second we got a red flag that comes up that says Bernie lost the second meeting without communicating with anybody, we're there. I mean, we're calling cell phone, we're calling home, we're calling his Bernie's mama, we're calling his lover, we're calling whoever we can get, tracking Bernie down. And push comes to shove, he and I'll get in the car and we'll go see if we can find Bernie. That's a very different kind of monitoring, agree? Old style, that's what we're talking about.